Okay. Good morning, everyone. My name is Masimba. So I'll be giving the first talk on revisualizing the path to data standardization. And I guess we're going to use COVID views as an example. I guess the old adage that when life gives you lemons, make lemonade is quite appropriate for what I'm about to share. So I think if we remember at the start of 2020, end of 2019, COVID presented a number of challenges to the healthcare industry. And I think one of the biggest ones that we faced as a company, in addition to the ones everyone else faced, is just from a data perspective, COVID really was a bit of a curveball. To give an example, some of the challenges are that traditionally ICDs don't capture outcome on pathology tests, and I guess for something like COVID, that is essential. In the hospital space, ICDs were designed to report on surveillance of a disease. And at the time, remember when COVID came out, the World Health Organization released two ICDs with respect to COVID, which is point 1 and U07.1 and point 2. And those specify firstly that a COVID test, for example, has been done. One is for a positive outcome, one is for not being able to detect the disease. And if we think about what life was like before COVID, I don't know if you remember what that was, but about 14, 15 months ago, what we were used to receiving is a monthly report. So to give an example, typically reports would come out, let's call it the 14th and the 15th of the month, which is effectively about 6 weeks after the first claim of being incurred. And with something like COVID, such a high latency for reporting was not acceptable, primarily because in order to be able to manage the disease, you need information on a more regular basis. So I think as the industry, and I think across all countries, the need to be able to report on a more regular basis was developed. So for example, in the private medical scheme market in South Africa, we started receiving daily reports. So those daily reports were claims, membership you already sort of need monthly, but then we needed to get pathology test results on a daily basis as well, as it would affect our ability to be able to report back and to give feedback on the scheme on the number of cases. Now, from a data perspective, I mean, if you can think about it, that we went from receiving one file at the end of the month. Now we got into a situation where we're receiving a file every single day. But now that you have the data, the real question is, what are you going to do with it? And I think just to take a step back from the actual data and to share just how we are as humans is that typically as human beings, I mean, I'll speak for myself, our environments are quite messy. Just the default nature of us as people is that without much discipline, we will sort of descend into some kind of chaos. To be able to report effectively as quickly as something like COVID, we needed something a little bit more robust. So if you think about the typical stages that we go through to be able to get to some sort of discipline is, if you think about, when you first had your own room as a kid, whatever it was, first it's kind of messy. Then you realize that actually, if I clear it up, it looks a little bit better and the chances are I'm not going to get grounded. If you go on from that, if you start to organize it, okay, my socks go in this cupboard, my shirts go in this cupboard, that helps a bit. And then once you standardize, you sort of have a quite a set way of how you do about your things. That helps. But the problem is, it means that each week you're going to have to do the same thing or figure out the same thing. Now, if you think about it within healthcare, is that there are lots of different administrators, and what is important is to standardize the information you get from different systems, because systems are different. And in able to do that, you need to build the discipline that allows you to standardize. And sometimes building the discipline means taking a step back from the data, building the discipline, and then attacking the problem. Because only by doing that can you get some reasonably good insights from the data. What I'll just share next is just the process we went about to actually do that. Because as I mentioned, we needed to produce daily reports on COVID-19 cases and experience for a number of our clients. And the way we went about it, if you think about the building discipline part, is that we needed to build a master reference table. Now, what this table is effectively, we needed to create an instance of a table which allowed us to be able to do all the COVID reporting we needed. Now, from a data perspective, if you think about it, you need to include membership in there. You need to have claims data in there, for chronic registrations, as well as pathology data. And another very important part is that if you remember during the course of last year, I mean, across the various countries, is that one of the challenges with COVID reporting was that they would report on it as what we term as the reporting date and not the event date. And what that would mean is that, for example, if there was a system issue or reporting issue, you could have very few cases one day and a big surge the next day. And what would appear as a big surge is simply just a reporting issue. So we adopted reporting on an event date, which you typically call a service date, because that allows you to be able to do more meaningful analysis because you've standardized the way you're reporting. But one of the biggest changes about how we work versus how we used to before COVID is that we had pathology results. And in creating this master reference table, pathology results trump ICD information for the simple reason that even though, for example, we got two ICD codes to use, how people used it was left up to interpretation. As an example, let's assume in the first month of the breakout, someone presents in front of a GP with all of the COVID symptoms. Now, they haven't been tested, but they present with all of the COVID symptoms. Is the doctor going to use 7.1 or use 7.2? So in essence, we needed a third data source that allowed us to be able to check the credibility of everything else we had, because being able to report on whether someone is positive or not was one of the most important things. And I think if you think about just 2 years ago, we had very little exposure to pathology data. It was extremely limited, but in order to be able to build this table, we needed to be able to incorporate pathology data into the data we received, number one. And number two, by incorporating the pathology data, interestingly, it reduced the lag with which we could report. Because, for example, at times, because pathology data can release information faster than we typically get from an administrator, is where it would typically take us, let's call it 7 days to understand the full case that are reported. By including pathology data, we could almost half that time and have sort of 95% of all positive cases on a day known within 3 days of the time a test was performed. In addition to pathology data, two other very important sources of data which we typically don't use or which are typically not used is hospital authorizations, for the simple reason that to be able to actually manage the disease, cost is a separate thing to be able to understand what hospitalizations are happening. So there's quite a big reliance placed on authorization data. And the last one, which is something which always intrigued me, I mean, I've been in healthcare for a number of years, that before COVID, reporting on number of deaths was a bit of a novelty. And we needed to be able to report on deaths because that was a key metric to be able to understand our progress in actually managing the disease. As with all actuaries, we can't build a table without some kind of a model or something that seems to complicate something which is simple. So we did something similar to that. So we built a simple multi-state model. And what it simply does is that in that master reference table, you can either be healthy or have COVID. But then because you also need to report on deaths, we need people to understand when someone ends up in the dead state, are they coming from healthy, which we don't count in our COVID stats, or are they coming from having COVID, which we then count in those stats? Because it's quite important to be able to delineate those, that in as much as COVID is happening, people do pass on from other reasons. And literally on the combination of these things, the multi-state model, being able to aggregate all of these different sources of data into our data universe and into the master reference table, we were able to report to schemes on a day lag. So for example, we would get data today, today's data we would get in the morning. In a few hours, we'd process that data and be able to produce reports that we share with our clients on a daily basis to be able to help them to manage the pandemic. Now, the end result, I'll start off with what you're sort of used to seeing. What you're sort of used to seeing is something like this, which is what we would call a vanilla type of graph. It's simply a number of cases, a rolling 7-day average, which is typically a lot of dashboards out there in what we see. Now, if you apply a little bit of intelligence and make it a little bit fancier, you can incorporate the various levels. So these levels are based on South African experience. You can report a little bit on the waves, wave 1, wave 2, where important events have happened. For example, the Day of Reconciliation is quite important in South Africa because that was just before the surge. And the challenge, however, with that is that it is still limited. You aren't using all of the available information which is available. Now, if we move down to what we were able to accomplish by simply aggregating the data using our master reference table, is that we were able to produce views which incorporated a number of different metrics. So for example, what you're seeing is an example of something we would produce on one of our clients, is that we were able to produce the top figure you're seeing is that we're able to produce the number of tests, positive tests per day, total tests. So that's something that's pretty standard. But then if you look at some of the other things at the top, is that these admission rates, for example, that we've calculated at the top there, those are being produced on a daily basis based on authorization data. And if you look at the graph below tracks these admissions and shows when there's a peak or a decline. And as you can see, it pretty much mimics wave 1 and wave 2. But up until this point, one could argue that a lot of the stuff we are showing is quite similar to what is being shown on an aggregated level for the country. But there's richer information that medical schemes keep, in particular cost data. Now, I'll start off by explaining the one on the left, which is simply your in-hospital costs. So we were able to report on in-hospital costs, being able to report it by age band. That's something you typically expect. But I think the graph below is something that's a little more impressive, because what we were able to do is that in real time, inside inverted commas, what we're able to do is to get the data, process the data, allocate members or beneficiaries on a scheme into different risk categories. So people whom are high risk, whom are highest from a health perspective, have a significant condition, all the way down to people who would classify as healthy, and a small portion where there's insufficient data. And able to understand which one of those risk pools is driving your in-hospital and out-of-hospital costs. Now, from a management perspective, this is a high-level view. This is able to be broken down all the way down to the specific beneficiary or member, for example, where there's a need to intervene. Now, during the time of a pandemic, I mean, information like this is invaluable, because if we are going to, for example, I mean, now we're having the vaccine rollout, is that if you extend what you can do at this, is that which one of your beneficiaries should you target first from a cost-cutting perspective? And this kind of view allows you to access that information. And the one other thing that I think I did mention to mention on this is that, in as much as it was important to get information to our clients out as quickly as possible, what is also important, format that is easy to understand and easy to interpret. And we invested quite a lot of time in simplifying the technical stuff that's happening in the back end, to be able to give people a very simple view that summarizes all the information they need to be able to manage the disease on an ongoing basis. Now, if we extend this to what some of the uses we could apply this to from a consulting basis, we are a consulting business, and we do aggregate our data to be able to give our consultants a broader view. So for example, some schemes are really big, so they have a good sense of what's happening just by looking at the old data. Some schemes are smaller, and that's not the case. And what we were able to do is, by aggregating the data, we could produce daily views, which we were able to understand what is happening across our data universe, because this was important as we would inform some of the advice we'd give to our consulting clients. So this, for example, is a graph which is produced entirely from the inside data universe. What you'd see, it mimics the first wave and the second wave as seen in South Africa. And in addition to this, on a daily basis, we would also do the same thing with NICD information. So on a daily basis, we were pretty much producing views on all the information we had available, because this informs your view of what's happening, where we are in the disease. Are we going into a second wave? Are we going into a third wave? And one other thing which we produce, which is a little bit different from what a lot of people produce in South Africa, is this SFC graphs, which effectively is a graph which allows you to understand the different phases of the disease you're going through. So if you look at this graph, there's the gray lines. The gray lines give you a 95% confidence interval. The red one is a trend line. And the way this graph works is that you fit a distribution, and each time there's an inflection, it goes into a different phase. So if you think about how COVID progressed in South Africa, if you look at phase 3, that's when the second wave came around and there's an inflection. So cases surge. Then as you're on the decline, it's a different phase. And such information assists us able to inform our clients, because at the time, for example, that the first wave was happening, we needed to set budgets, and being able to have this kind of information on hand is incredibly valuable. But just to summarize, and just to close off my presentation, the reality is that trying to manage without data is like walking in the dark. I mean, you might get to where you're going, but at what cost? And I think as an industry, and I guess as a country as a whole, what we've realized is that the need and the ability to be able to aggregate all the information which you have available is invaluable. I mean, 15 months ago, it would have been very difficult to be able to create standard views across everything. So for example, 15 months ago, we weren't able to report at a global level at something like this. But through collaboration, now we have been able to do that. And the reality is that no matter how big of a medical scheme or insurer you are, when we aggregate our data, everyone's views broaden, because there are corners of the market which, no matter how big you are as a scheme, you don't see. When you're a small scheme, the benefit is obvious and it is clear. And I think, just as one of my parting shots, that as an industry, it's important to be able to find areas of mutual interest and collaborate. The reality about healthcare is that we are sort of all in the same ocean, and if there's an oil spill, there's an oil spill. No matter who you are, it will affect you, and the ability to be able to collaborate on things of mutual interest is invaluable. And simple examples of some of these things are, COVID-19 was a starting point, and the amount of collaboration across the industry was commendable. Fraud, waste, and abuse is an area where there has been some collaboration. For example, there's a project through the Board of Healthcare Funders that happened in South Africa a few years ago. I think it is still ongoing. Was another area where everybody stands to benefit. But then other areas is provider benchmarking, to be able to improve the quality of care members receive. And something which one of my colleagues will touch on a little bit later is voice of the patient, which is simply being able to incorporate patient-reported outcome measures into the data that we keep to be able to improve the system. That's the end of my presentation. I think I would like to give special mention to our IT team that's led by Fahim Suban, a couple of other members in his team who are quite involved with Wilhelm and Titch. I think special mention goes to for the heart that they did their fair. I can appreciate that most of you have either never heard of them or seen them, but if you've heard that old actuarial joke that the shy actuaries look at their own shoes, the really confident ones look at your shoes. These actuaries that we have in particular are probably a little bit too shy to even look at their own shoes. Thank you.
Thanks, Masimba. So I've already started sharing my screen. Can you just confirm for me that you can see the slides in full view?
Yep.
Okay, great.
Yes.
Okay, so today I'm talking about quality. I think usually when you see someone talking about quality, they probably have a bit more gray hair and a bit more wrinkles than I do. But I think the fact that I'm talking about quality today is probably, a sign of the times. We have young people who, have smartwatches, smartphones, and all kinds of healthcare apps and devices that they're using to track their healthcare. And, there's lots of development in terms of devices that you can use for home monitoring, looking at your glucose levels, blood pressure, heart rates. So I think we are entering into more of an age of consumerism in terms of healthcare. And of course, consumers, can be demanding and have certain demands. And that's the same when it comes to the quality of healthcare. So I think we're definitely moving into an age where consumers will demand more in terms of the quality of their healthcare. So if we look at where South Africa is on its trajectory in terms of the quality of healthcare, the Health Market Inquiry has demonstrated, that there's a lack of reporting on quality and outcomes. So that's not to say that there aren't organizations who are measuring quality and looking at improvements in quality, but there's certainly a lack of reporting on quality. Now, for those of you who are maybe unfamiliar with the literature on quality measurement, let me just explain the main areas that are considered within quality measurement, which are systems, processes, and outcomes. And I'm going to use an example just to explain each of those areas. So if we think about washing our hands, if you're thinking about looking at quality in terms of the system, that's thinking about at the organizational level, how many hand sanitizers do you have in a hospital? Are there automatic dispensers for hand sanitizer? Do we have enough basin So are they, conveniently located so that it's easy for nurses and doctors to use them as they're interacting with patients? So that's thinking at an organizational level. How easy is it for people to wash their hands? And then if we think of the process, you might want to look at compliance, look at the percentage of staff in a hospital that comply with your hand washing policy or hand sanitizing policy. And then if you're looking at the outcome, you would want to look at measuring infections in hospital. So that's just a brief example to explain each of these areas that are the typical areas we look at in terms of quality measurement. So looking at a system level, that's really looking at the organization, where the healthcare occurs, the type of environment, the staffing ratios, access to equipment, and thinking about the process in terms of quality measurement. These are really your more evidence-based indicators. It's looking at whether clinicians are following the appropriate care guidelines, and these are really reactive levers that you can use to change behavior in terms of healthcare, using evidence-based medicine to improve healthcare. And then looking at outcomes really reflect the end results of the care that a patient's receiving. And this is what I'm going to be focusing on a bit today in my talk. And Daniel, who is speaking after me, will also be talking about outcomes. And if you've chatted to any clinicians who are, measuring the functionality of their patients before they've had an operation and after they've had an operation, you can see what a thrilling experience it is for them to actually see how a patient's functionality can improve after an operation. So, it's not only rewarding for the patient to have that improvement in their functionality or quality of life, but it's also rewarding for the clinicians who see the functionality and the well-being of their patients improving. So the outcome is really looking at, have you improved the patient's life, or have you made the patient's life worse? And in terms of quality measurements, what are the sort of purposes that we can use quality measurement for? We can use it for research. So if you're investigating a new treatment regime or new medication, to look at whether it's actually improved the patient's well-being or if it's done any harm towards the patient. You can also use quality measurement for improvement. So this is just trying to make the system better. And we can also use quality measurement for judgment. So this is when there's more of a link of quality measurement into contracting, into performance measurement. And of course, when you bring quality measurement and performance measurement into contracting, you'll always have winners and losers, but that's the nature of competition. So in terms of in the South African context, we probably have a bit of quality measurement in terms of improvement and judgment. But, if you're thinking about your journey in terms of quality measurement, probably the first step that you want to be taking is looking at improvement. This is kind of an area that's a bit more agile. You can look at improvement initiatives, see what kind of impact they have. If they have a good impact, you can continue with them. Or if you're not seeing enough of an impact, then you change your improvement initiatives so that you can get more benefits and change the well-being of your patients. But we do also have some contracting of networks, some judgment in terms of quality measurement that happens in the South African context as well. So now, just to make this a bit more tangible, looking at some specific quality indicators. So this is based on quality indicators from the Centre for Medicare and Medicaid Services. And here they actually use these indicators to publish ratings on their hospitals. So this is used for judgment in the USA environment. And here you can see the indicators that we're looking at here are, quite relevant for South Africa as well. Something that we're used to looking at if say you're looking at hospital experience, you want to investigate mortality, readmissions, patient safety. And you can see this is also a mix of the different type of quality measures. So there are some process measures where you're looking at the effectiveness of care, so where the clinical guidelines are being followed, also looking at the timeliness of care. So this is, say, if a patient comes into the emergency department, Are they able to get the care that they need within a reasonable waiting time? And efficient imaging, also a bit of a process measure. And I think also quite relevant during these COVID times, we could think of that indicator there in terms of efficient imaging. So this is, whether you, in this specific example, they were looking at X-rays and, whether it's clinically appropriate to give X-rays for certain conditions. But, during COVID, we've seen a complete drop-off in utilization and lots of questions being asked around how much healthcare utilization is actually real needed healthcare utilization. So I think that's also important to consider in terms of quality going forward. And then patient safety is always a major indicator that most organizations are looking at. So now if we just move to looking at some international experience to see what we can learn there. Looking at Australia, Australia has a Commission on Safety and Quality. So again, there you could see a big focus on safety. These are largely government owned and run, but they centered on collaborating. So collaborating with private participants and the providers as well. They also have a My Hospitals Government Initiative, which publishes data on public and private hospitals. So you can see they already have a reporting mechanism where they're publishing some information from public and private hospitals. There on the right, I'm also showing an extract from the College of GP Practice, where they're publishing results on their patients' experience of GP practice. And at the moment, Insights is also running similar sort of investigations on GP practices, very similar to what you see here. Did the GP listen carefully? Did the GP show respect? Did the GP spend enough time with you? And you can see there's generally positive results there. And often what you find with general practice is that you've probably been with your GP for a number of years. So, you would only be with your GP for a number of years if you are satisfied with that GP and happy with that GP. But you can see that this information would become very useful for a provider who's maybe setting up a new GP practice, maybe a young provider. Or also useful where you're looking at people who are moving between GPs. Maybe they haven't found a GP that satisfies them yet. So then those results can become quite useful. Looking at the USA, they are heavily invested in quality measurement. They have a number of indicators, over 1,000 quality measures registered with the National Quality Foundation, also the Centers for Medicare and Medicaid, and the Agency for Healthcare Research and Quality also have specific frameworks and indicators that they look at in terms of measuring quality. And there are also independent organizations like the Institute for Healthcare Improvement, which is actually worldwide known now, as well as there I'm showing on the right is an independent organization, Leapfrog, that actually works with employers. So here you're actually seeing employers getting involved in the care of their employees as well, going to hospitals, looking at whether hospitals meet certain standards in terms of safety. You see there's also a role for employers to play, but specifically in the USA, you see there's a number of measures, over thousands of quality measures. And in the USA, there's actually a call to reduce the quality measures so that they can focus on particular areas, because it actually becomes quite cumbersome to be looking at such a high number of quality measures, and forming composite scoring of all of these quality measures also becomes quite complex. So there's a call to reduce the number of quality measures in the USA. And then looking at the UK, of course, the NHS plays a big role there. So, but there is also a mix of government and independent quality measurements. The Care Quality Commission is the independent regulator of healthcare in the UK. There's also the National Institute for for health and care excellence, which has particular quality standards. And then there is also some reporting again at a private level, so private hospital information network, which actually came out of a market investigations. They were appointed by the Competition and Markets Authority. So yeah, you know, we're seeing an organization, an independence organization there in the private sector being appointed to monitor quality, which, you know, we were hoping would come out of the health markets inquiry in South Africa, but at this stage there's been little action there. And of course, you know, the country's priorities are also focused on COVID at the moment. So hopefully out of the health market inquiry, we are going to get more of a central organization in the private sector that can monitor quality. And there on the right, you can also see that data is quite easily accessible in terms of reporting on quality in the UK. Yeah, looking at hip replacements and knee replacements, looking at whether the patient has worsened or whether that patient has improved. Yeah, you can see the majority of patients have reported an improvement, and they've got response rates to these investigations, you know, from about 15% to 30%. Quite a good response rate. Yeah, you can also see the hospital ratings in England here. The good hospitals are shown in green. You have some outliers which are outstanding and or inadequate in red and blue there. And then you have also a good number of yellow hospitals there who require improvement. But again, you can see here a focus on safety. So safety is often a big focus. So now if we move back to South Africa, just to think about, you know, what kind of public information we have in South Africa, there is really a lack of reporting. There isn't anywhere you can really go to get industry sort of quality metrics. Of course, at a scheme level or hospital level, internally, there'll be investigations on quality, but there isn't really a sort of public repository that you can go to look at patient safety or quality. So this is something that Insight's actually looking at. We're looking at launching a data platform later this year, and we'll chat about that more at Foresight later this year, where we're going to be incorporating some information that's publicly available. So just illustrating publicly available information, and then also for our particular clients, linking that publicly available information to their own information to make comparisons. So this is what I'm showing here is just extracted from the reports of Mediclinic and Live Healthcare, where they're reporting on patient safety in terms of pressure ulcers, falls, medication errors. So you can see falls and medication errors really the bigger concerns. You see higher rates there, and you can see how the medication errors, both Mediclinic and Live Healthcare, have had improvements over time there. 2019 showed in the dark green, so you can see how the medication errors have come down, but there really is a sort of lack of using this sort of public information to everyone's benefit for comparisons. So finally, to sum up, you know, if looking at starting a quality framework and measuring your quality, you need to formulate your focus areas, because as we see in the USA, you can come up with a vast number of quality measures, but that can also then become quite cumbersome. So, you know, formulate your focus areas, formulate your framework, your quality framework, and then, you know, you need to try and use data to the maximum benefit. So there is some publicly available data that we can use, and we're probably not using it in the best way we can at the moment. And then also visualize the data. This maybe sounds a little bit simplistic and obvious, but I think we often forget how useful it can be to visualize the data, because it actually provides motivation for change. You know, if you've started some improvement initiative and you can, you know, start to see that in the results over a couple of months, that's a really good motivator to change your processes in terms of improving quality. And, you know, it can be quite complex to introduce quality over the whole system. So, you know, you maybe need to think about starting off with pilot projects where then you can look at the whole system and processes and outcomes all together to see how that can improve quality. Okay, so now we're going to have Daniel, who will give us a bit more of a practical example in terms of quality measurement, and he's going to take us through Voice of the Patient, which is being deployed in Australia, but we are also currently using it in South Africa. So this is also a full service offering that we have in South Africa, but I'll hand over to Daniel now. Thanks.
Thank you, Gizelda. Can you just also give me a thumbs up if you can see my screen and if you guys can hear me?
Yeah, carry on, Daniel.
Yes, great.
Great, thanks guys. So thanks for that intro, Gizelda. Yes, so today I'm going to be talking about a platform that we recently launched in Australia across most of the private health insurance funds. And the aim of that platform is to use some of the metrics that Gizelda has referred to in terms of quality and outcomes metrics, and transform those metrics into value-based funding contracts for hospitals. And so this idea of value-based funding isn't really something that's new. It's not really something that's novel, but it has been something that has been a point of great contention across many contracts or across many markets. In Australia, particularly, it's something that while the Aussies are quite forward-thinking in terms of quality metrics, there isn't really a lot going on in the ways of value-based funding in terms of play for outcomes or pay for outcomes. And the reasons for that are actually quite interesting. So if we think of the way that we would traditionally set up a value-based funding model for hospital services, and I will provide some more context of the Aussie market, just so you guys can have a bit of a view of what that market context looks like. But basically, the starting prerogative there being price or cost is something that's well known in the Australian and South African market. It's well coded. The data is very well standardized, more so what we're used to in South Africa. But this question around actual outcomes is something that's quite fuzzy in this market. And that's not an Australian specific characteristic. And the reason for that is different people have got different ideas of what good outcomes are. Good doctors generally know, and they're already engaged in measuring outcomes. The challenge is that a lot of the other stakeholders in that market don't have the same outcomes, or if they do, they're talking about different metrics. So for example, a hospital might measure one thing that it sees as a specific outcome, whereas a healthcare funder looks at something else that they're looking for a healthcare funder or for a particular outcome. And this perspective issue creates challenges when we start contracting around these metrics. And this was the particular problem that we were asked to solve for this group, or this purchasing group in the Australian market, to put together a platform using various tools and applications that actually does this appropriately and correctly. And so a little bit of context about the Aussie market. Australia, as Gizelda has mentioned, has got a universal healthcare scheme called Medicare. That's available to all Aussies, and everybody's able to access care there, basically for everything that you'd need. On top of that, you've got ancillary or top-up cover. Now, there's some things that those products can't pay for. So, for example, consultations, medication, are things that you cannot buy from a private insurance product. But you can buy services for elective procedures. So you buy freedom of choice and choice of your doctor, a fancier room. But you can also purchase ancillary covers. So for example, dental and optical and physio services. And then there's a portion of that relates to out-of-pocket payments. So both these systems have some holes in them. You actually ironically expose yourself to higher out-of-pocket payments if you go private. So it's a bit of an interesting scenario there. But where we looked at specifically regarding quality was in the private sector. Now, as Gizelda pointed out, there's quite a bit of work around quality and value for the public sector. And while that does spill over to the private sector, the context of the procedures and the way that those services are being delivered isn't wholly appropriate for those same metrics. So we had to do quite a bit of work to put together a platform that's agreeable to all, but that actually then provides you with the right kind of metrics. And the traditional way that contracting was conducted by this particular partner was with a lot of information around administration data. So that's traditional claims data, as we would call it. And there's quite a bit of information at a standardized level from complications. So those would be adverse events or never events. Those events luckily are coded uniformly across all hospitals when they happened. So that information was fairly robust. But that led us into the scenario where funding was basically based on volume, and hospitals were actually discouraged from the private side to take on more complex patients to such a degree that you virtually would end up in a life-threatening situation if you rushed to your nearest hospital. If you were bitten by a red-bellied black snake, for example, you'd have some serious issues. You'd have to go to a public facility. If you're a child and you get injured, our eldest broke her arm the other day on the netball court. It was no option for us virtually to go to a private facility. We had to go public, because that's where those kinds of more complex patients get handled, because the incentives weren't geared towards them. What we've put together is a voice of the patient platform that looks at different sources of information at a standardized level across multiple providers in the market. So that includes roughly about 27 of the 36 health funds in the Australian private health insurance market. Belly buttons wise, it's about 2.5 million lives. And then we combine with that the administration data, the data on hacks and complications, and also the relative performance of hospitals to get to a platform where we're able to say one hospital's performance compares relatively to another one for a particular procedure. That's the aim. That's the platform that we've put together. And the aim then is for those hospitals to be part of that platform through the funding mechanism, and that they can both be incentivized for achieving good performance, but also be incentivized correctly for taking on more complex procedures and have the capability and incentive to invest in those kinds of procedures as well. And so what we found, just in a brief nutshell, for those that aren't familiar with the terms of what experience and what outcomes metrics are, experience metrics are information that's collected directly from the patient about their experiences when they were in hospital. They relate to actual measures. And traditional experience measures are sometimes confused with things like, was your Wi-Fi signal strong? And did you have a nice view from your room while you're in hospital? Those aren't really experience metrics. Experience metrics, done the right way, should be clinically driven. They should be specific to the procedure that you're going in for. And they should inform you about the kind of treatment that that patient received in hospital. And I'll give you an example. If you're going in for a cardiac treatment, an experience measure would be, did that patient feel cared for while they were in hospital? Did they feel safe? Did the procedure provide, did the attending staff provide them with sufficient information around their procedure? These metrics are collected ideally as close to discharge date as possible. So while that experience is fairly fresh, there's a bit of an agency problem if the hospital collects those himself. If you're sitting there with tubes and an IV and a life-sustaining machine attached to you, and the hospital nurse comes and says, do you think we're doing a good job? That's not necessarily the best point where that's collected. And then the alternative, or the counter to that, is the outcomes in terms of what does the actual outcome of the procedure provide you. So if you've had a knee replacement, in 3 months' time, after you've gone through rehab and had the procedure, has your functionality actually increased? Can you get up from a chair easier? Can you go up a flight of stairs easier? And the point there really is about understanding that the procedure deliver what you actually paid for. A great example, or a classic one in that regard, is pain. Lots of people have got pain in, say, a particular joint or their back, and they think a procedure will solve that issue. And traditionally, outcomes metrics for general pain surgery, back surgery, for example, are not nearly as good as specific procedures to fix a break or a ligament or something of that nature. So the point I'm making is that these metrics are very nuanced. They need to be clinically specific, and you can't just go and do a general survey or a general questionnaire when you're looking to look at what these metrics are, especially not if you're going to be attaching payment mechanisms to them. So the Voice of the Patient platform is a platform that we have built in partnership with a number of other organizations, as well as using the best examples of the national, international research, as well as local developments coming out of our own Internal Quality Commission down here, to put together a clinically informed platform of interactions that we have with a patient right after discharge, and then following a couple of months after that, after they've had time to recover, to provide this picture that doesn't currently really exist in the private health sector. And what's exciting about that is you're actually creating the data as you go. So for example, Gizelda mentioned in her presentation, wearable information or information around steps and activity. And that's very exciting in its own right. And the information is very valuable, but it's already there. So it's about analyzing that data. The key portion here is about actually creating the data and actually asking the right questions. And there's a number of examples of organizations that provide a blueprint, ICHOM being one. And that's really a great starting point, but that really is what it is. ICHOM is like a hardware store where you go into and you buy the different bits that you need. The actual interpretation of that information and the contextualization of it in the context of what you're trying to measure is very important. And that's exactly what Voice of the Patient does. Voice of the Patient is a platform that connects patients to the right information and the right questions. It's something that we've been quite surprised with in terms of just the response rates on their own. So normally, if you're looking at international response rates for a quality survey or an interaction survey, if you get between 15 to 17% response rates, you're doing quite well. On Voice of the Patient, we're routinely sitting between 35 to 40% response rate for those policyholders. That might be related to a number of factors. The fact that it's a private service that people are purchasing is definitely one factor. They like to provide feedback. The Aussies also like to complain, so that might be another reason. But the point here really is that we are getting great responses through this data, and it's creating an opportunity for us to actually look at the data in more detail. And I actually want to show you what the platform looks like. So if you bear with me, I'm going to just try and switch modes here, and we can just see if we can go into the actual platform itself. It's always fun when you're switching between different technical prerogatives themselves. There we go. So just give me a nod there if you can, or a thumbs up on if you guys can see the platform. Great, thanks guys.
We can see.
Thank you, Barry. So the platform that we've put together has got two components. There's some parts that that's a bit sensitive, just a bit sensitive that we're not going to be sharing today, but I'll talk to them. But here, what you can see on the screen now is a visualization of actual experience metrics at a hospital level. So these show you the number of admissions at a particular facility. They show you a particular health fund and also the fund, the hospital that we're actually looking at. So it's at a hospital level. The data has been dummified here, so it's not actual data, just because there are some confidentiality issues. But there's a couple of very interesting points that we can see from the information in terms of it being representative of what we normally see. And what the data or the platform allows us to do is take patient experiences and split them up into whether they refer to the doctor's treatment, the hospital's treatment, the staff, the general responsiveness. And we can then compare that at an individual procedure level between different factors. So for example, if we want to see what experiences are like at this particular facility, we can look at specific factors, say at a condition level or a DRG level, and we can see how does it differ for, say, cardiac procedures versus general surgery across all those facilities. And the capability that you have there is the ability to see exactly what those factors are and what they look like. Experience metrics generally tend towards the positive, and I'll talk to why that's interesting and relevant. But you can see the kind of seeds of a value-based contracting prerogative here. And even if we just had experience metrics, we could potentially say to this hospital, based on the risk-adjusted benchmark there, we want you to maintain a level of at least 80% or 90% as a score over the next 5 years. We can then also see what the results look like for outcomes themselves. So for outcomes here, we're looking at whether or not the procedure actually delivered what we wanted it to deliver, whether or not that procedure actually provided us with an improvement or an unchanged status. And as you can see there, the vast majority of procedures do improve the life of the policyholder. The question is by how much, and whether or not that particular improvement is something that we can tie back to the actual cost of that initiative. Additional risks to, say, readmission or things of this nature. And again, we can split it out for a particular condition. And we can look at this at a very nuanced level and put it together with specific individual surveys. If we want to see what the individual results were for a particular patient at a survey level, we can also see that per condition, or we can see this particular survey is giving us these results. And why that's important is the platform is designed in such a way that we don't want to be tied to a particular survey or questionnaire. We want to be able to adapt it for each environment that we're working in. So, for example, this platform has got a number of Australian-specific surveys in there. The South African one has got a range of South African-specific surveys. But the idea is that we become a survey or questionnaire agnostic platform that collates the best of what's available internationally and puts it together in a platform that I'm going to bring you back to some slides and then I'll jump back into the platform. Are you guys still there? Can you still hear me?
Can you still hear you, Daniel?
Okay, so my Zoom is frozen, so I'm responding again. but let's see if it pops back up. But the key theme there is that we're seeing some amazing results coming through the platform. So I'll talk to the results until we've got visuals again. But for example, we're seeing significant differences. Okay, looks like we have got some life here again. I'll just bring it back up. Let's see if it's going to work now. Now we go back into. Can you guys see my screen?
Yes, carry on.
Yes.
All good.
Okay, but are we on which? What are we on? Are we on the presentation?
We're in presentation mode.
The dashboard? Beautiful. Okay, great. But so anyhow, while we wait for the slides just to pop up, the actual response rate differs quite a bit between different prerogatives. So we'll find, for example, that obstetrics have got a significantly lower response rate than something like orthopedics. And while that might sound intuitive, new moms don't want to be bothered, those kinds of results are still important to us. And so what we've had to do is we've had to adapt our strategy in terms of the way that we engage with policyholders, the time that we send information or requests out to complete surveys, the actual date that we send the information out versus discharge date. And we've been able to boost the response rates quite a bit using this kind of information. And so what we found is that the information is also positively skewed, as I said, especially experiences. Patients generally love to rant about how great their services were, but we're also finding some fascinating information at an anecdotal level, individual level, when experiences aren't good. So for example, we recently had a case where someone had significant mistreatment in hospital, and this actually led to a mental health admission. Now, traditionally, the funder would never have known that these two things are linked, but now they can actually launch an investigation and find out what the actual factors are then. What we also find, what's important is that while responses are positively skewed, specifically for doctors themselves being quite popular, the margins do make a difference. So a recent study found that a 1% difference in experience scores correlated to a 5% decrease in admissions. So a 1% increase was correlated to a 5% decrease. Again, we're not saying that's a causal link, but that does create the opportunity to have an evidence-based platform to say to hospitals why we would like you to have a specific parameter or guideline that we contract on. So these forms of data all feed into a multifaceted funding platform as a combined factor, and not necessarily as individual metrics that have an extreme amount of value. So I just want to see if I can pop back into that. Can you just confirm for me what you guys are seeing now?
We can see the system.
Beautiful. Here I want to show you an actual platform that we've designed for the outcome. This is the funded group, and you can see their visualization of all of the hospitals that we have in the platform. As I said, it accounts for approximately a third of the entire market by volume of admissions, and roughly about 27 of the health funds themselves. So if we choose a particular hospital, I'm just going to show you what that would look like, and let's choose that top one there.
Daniel, your sound is a bit intermittent.
I think it might be a bit of a signal issue on my side, so I'll try and.
We seem to have lost Daniel. His connection's dropped. While we're waiting for him to rejoin, there were a couple of questions around the pathology data and the way that that was integrated. Christoph, you wanted to do a segue into that?
Yeah, I was just looking at the chat between Matthew and Wilhelm, and perhaps this is useful while we're waiting for Daniel to reconnect. Wilhelm is in our IT team. He's been doing a lot of work over the past few months, really the past year, to integrate more deeply and in real time with pathology labs. Perhaps we could just take 1 or 2 minutes for Wilhelm to talk about that. I just think it's important that everyone is aware of the capability to do that. We found over the last year that labs have been particularly willing to cooperate, whenever a medical scheme gives permission to share data. So Wilhelm, he told me he has a dodgy connection at the moment, so maybe he's not going to turn on his video. But go for it, Wilhelm. Maybe you can just share a little bit more of what we've achieved over the last year. Thanks.
Hi, everyone. Can you hear me?
Yes.
Yeah, sorry, I've got really bad signal. So basically, our pathology data consists of multiple different kinds of data. In the traditional sense, we would usually receive claims data where we would have a tariff attached to every claim. But with COVID, the need for urgent and continuous reporting required us actually to delve down into the raw pathology data, which it opened up the world of LOINC codes, something we haven't dealt with in previous experience. But from that perspective, we get data from administrators. So certain administrators would have a consolidated view of pathology that gets submitted to them from all the different pathology labs, where they would then do the interpretation, effectively distilling a pathology claim down to a tariff code and a result text, which would just be something like positive or negative. But for AMPATH specifically, we actually developed a interface where we would get data on an hourly basis every time they do a batch run, which then required us to then interpret the individual LOINC codes and then link them to specific tests like a PCR test or an antigen test. Then pathology results are rather free text. So we had to then develop something to interpret all the different types of well, firstly, languages, because obviously there's Afrikaans and English, and test results can be in either, to then just go and look for, was the test positive, was the test negative, or similarly, was the virus identified or not. As I said, initially it was a bit more of the Wild West at the start of the pandemic, but as more information became available, the data standardization became a lot better. Christopher, I don't know if there's other specific questions.
Yeah, I think maybe just at the moment, the only thing we need is instruction from a medical scheme, and we can interface with all labs, in some cases in real time, and in some cases on a daily basis. And maybe to add to that, that we take extra care really to ensure that the data is stored on our servers in encrypted format and not the staff at Insight have access to that kind of information for security purposes. But there's a whole lot that we can do with this kind of information in real time. So perhaps that deals with some of the questions that Matthew had. I'm not sure if Gizelda, did Daniel rejoin, or do you think they have load shedding in Australia at the moment?
Daniel's back, so I think Daniel can start sharing his slides again.
I was basically done. I'm pretty sure Koala climbed on some pole and then crossed wires somewhere. But I think the point just that I wanted to make is what we found valuable with Voice of the Patient was that there is significant value in connecting all of these different data bits. And if you can do it in a standardized way across multiple participants in the market, hospitals, funders, that really is the golden ticket to make sense of the data in a way that is informed. What we've seen is the data that we're getting in the short time that we've run Voice of the Patient en masse is that we've had immense value from the interactions that we've gotten from patients themselves. We believe this is the future where healthcare is going in terms of funding, and we're quite excited about what the future holds with the platform as it currently stands in terms of the data that we are able to create with
it. Thanks, Daniel. And everybody that spoke today. I know we're a little over time than we intended. I suppose that's often the case. We're a little out of practice with these. We did them last year. Thank you to everybody that stayed. I just want to close off with 2 comments if I can. First is that, for us, quality measurement and quality reporting and analysis are an increasing area of importance for us. We've been investing in that area for the last few years. And now we're starting to see the fruits of that with the system Daniel showed you that we're very excited about having deployed at wide scale in Australia. It really was a great breakthrough for us to be able to deploy there. We'd like to see a world where in South Africa, quality information is as accessible as cost information. The cost information we've been working with for 20, 30 years. And we all have a good handle on that, but quality information remains a bit of an enigma, and we'd like to move to a world where that quality information is as accessible as cost information, not only for providers, so that they can improve, have something to measure against and improve, but also for funders, so that we can really move into that value-based contracting environment, and also for patients, so that they can make better choices about their care. And much of our effort over the next little while is going to be about trying to get stakeholders to see what we've done in Australia, embrace the proms and prems kind of measures along with the other metrics that Daniel was talking about, and we have those exact same capabilities here. We'd love to see that kind of deployment in South Africa. We may already be speaking to you, and if we're not and you're keen, then please reach out so we can chat about it. And then to touch on Masimba's talk, we'd really love to be in a place where we can share the kind of data that we find useful, like those aggregated COVID dashboards, which are the only sort of dashboards at a national level that are being reported on by service state, without the lags that you see in the typical national reporting. And so we'd love to, again, be in a position where we can report that kind of information consistently, publicly, in an aggregated, kind of safe environment for everybody to have a good handle on what's actually going on the ground. So thank you for sticking with us over the time. The panelists are going to hang around for a little while in case there's any last questions. But look out, as Gizelda said, for the next invitations as we build on our Foresight series for the remainder of the year. Thank you all very much for your time and for joining us today.